It would be presented by Dr. Kiran Chandran, and Dr. Chandran will be speaking on correlating gas and Blodi staging and SD OCT characteristic to devise a new MACTIL classification.
Good afternoon. My talk is on correlating gas and Blodi staging and SD
Even
OCT.
before you present, may I ask you what made you think in this direction?
So a lot
Was
of
it prospective or retrospective?
it was an observational study using our MACTIL data, which we have in multiple centers actually. So a lot of data has been done using OCT as diagnostic modality in MACTIL, but so far clinical classification has not come about using OCT. Although we had a clinical staging by gas and Blodi, but a multimodal imaging classification has not come about. So that is the interest in devising such a classification and validating the study.
Okay.
So the initial staging by gas and Blodi was done clinically, in which the first stage was characterized by leaking cholangiomas on fundus fluorescent angiography. The second stage was characterized by parafoil loss of retinal transparency. The third stage by right triangle vessels. The fourth stage was characterized by pigmentation, and the fifth stage by neovascularization. So as I told, the OCT has been used very frequently in diagnosing MACTIL, but so far staging classification using multimodal imaging, specifically OCT, has not come about. Emily Chu and colleagues from the MACTIL group devised this OCT classification system, and 7 grades were devised in this system. Starting with, and they use a target measure of best corrected visual acuity. So the grade 0 was characterized by no abnormalities. Grade 1 by non-central EZ loss, grade 2 by central EZ loss, grade 3 non-central pigment, grade 4 OCT hyperreflectivity, grade 5 central pigment, grade 6 X-rated neovascularization. And as a grade of the disease progress, the visual acuity also dropped. So ours was a multi-centric observational study involving 3 centers in India. So MACTIL eyes were recruited, initially staged according to the gas and Blodi staging and further corroborated using complete multimodal imaging. Inclusion criteria were confirmed MACTIL eyes across the different stages with gradable images. Best corrected visual acuity was calculated in ETDRS visual acuity charting with a visual acuity score of 0 to 100. MACTIL clinical staging was done as per gas and Blodi, and SD OCT features were studied. So the first one was EZ loss. As you can see in this figure, it was the disruption of the second hyperreflective band involving the outer retina. Then it's the outer retinal reflectivity, which was linear or over fusiform hyperreflective lesions in the outer or subretina, which was as bright as a retinal pigment epithelium. Then was a retinal pigment epithelial clumping and migration, which were hyperreflective clumps in the middle or superficial retinal layers extending from the RP with backscattering. And X-rated neovascularization, where clinically there was presence of lipids and hemorrhages, and on OCT, interretinal fluid or subretinal fluid with inner retinal thickening, as with outer retinal hyperreflectivity plus or minus RP clumping and migration. So more of these, any of these features can appear together. Hence, the various permutations and combinations were used to evaluate the best correlation with visual acuity decline. So the mean visual acuity change for each MACTIL category for both gas and Blodi and OCT MACTIL grading was used. Classification regression trees, that is predictive algorithm using machine learning, was used. It is a decision tree where each fork is split into a predictive variable and each node predicts the target variable at the end. So nodes were split into further subnodes until a terminal node, that is maximum branching, was possible in that particular tree. The data was split into 2 sets, that is training set where right eyes were used to construct a decision tree, and validation set where the left eyes were used to determine appropriate tree size. So the factors that impacted visual acuity were placed into order with other factors based on progression from good to poor visual acuity at baseline for both the right and left eyes. Results: 1,432 MACTIL eyes of 733 participants were recruited. Majority of females. Right eyes were recruited more than left eyes, and mean age was 52 to 68 years old. So in both the training and validation set, as per the gas and Blodi staging, majority of eyes were in stage 2, followed by stages 4, 3, and 5. So this was the OCT grading which we got after comparing the data. Our staging closely mirrored that of the Western population, in which grade 0 was no EZ loss, grade 1 non-central EZ loss, grade 2 by central EZ loss, grade 3 non-central pigmentation, grade 4 by outer retinal hyperreflectivity, grade 5 by central pigmentation, and grade 6 by X-rated neovascularization. And again over here, the visual acuity declined as a grade of MACTIL progress, but the only difference was that we had, in our cohort, the visual acuity is slightly better compared to that of the Western population. So this is a CART algorithm which shows that pigmentation is taken as a common attribute, and we split the pigmentation into eyes with central pigmentation and non-central pigmentation, and eyes with no pigmentation. So eyes with pigmentation had reduced visual acuity, and the grading of macule was in the higher grades. And as you can see in the right hand side, the eyes with no pigmentation had got better preserved visual acuity with grading between 2 predominantly. So this is an example of a 10-year follow-up showing macular progression on OCT using multimodal imaging using with fundus autofluorescence also. Initially, there are no changes, BCVA 6/6. Over a 2-year follow-up, again the BCVA 6/6, but there is appearance of IDZ loss, just sparing the fovea. Over a 5-year follow-up, the vision is still preserved because the EZ loss is just sparing the fovea, mainly non-central with non-central pigmentation. But once the EZ loss progresses to the center, and when the pigmentation again involves a foveal center, the visual acuity drops. So this is a figure using multiple imaging modalities with color fundus photo, blue reflectance, fundus autofluorescence, and SD OCT. And it was done stepwise according to gas and Blodi staging, and we compare the gas and Blodi staging to the devised OCT classification. And as you can see, the grade 1 where vision is 6/6, there is only non-central EZ loss. Central EZ loss is happening when the vision is reducing to 6/9, with non-central pigmentation where the vision is again dropping to 6/15. Then there is outer retinal hyperreflectivity followed by central pigmentation and features of X-rated neovascularization where the vision drops to 6/60 in the validation set eyes. So vision acuity decline was not well represented in the gas and Blodi classification, and vision acuity decline relates more to OCT features rather than that seen on clinical fundus photo as devised by gas and Blodi. So MACTIL OCT classification in Indian cohort had similar findings as the established classification in the Western cohort, and it showed correlation of OCT findings with progressive visual acuity decline. So OCT being the single most informative imaging modality in MACTIL, therefore a grading system using OCT was needed to determine the grade as well as rate of progression and prognosis. And our findings correlate with that of Western cohort, signifying the important grading severity to assess the risk of progression and vision loss. Thank you.
I just have one more question to ask you, Dr. Chandran, in terms of, you said that the visual acuity correlated very well
Yes, sir.
with the OCT changes.
OCT findings, yes,
right?
Yes,
and this was also very similar to the Western data.
Western data, yes.
Now, and these you had data recruited from 3 centers.
3 centers, right, sir.
Right. Yeah. So, what is your new MACTIL classification? Because your paper said that you want to devise a new MACTIL classification.
Yeah.
Can you show me, because I could not, maybe I overlooked, I could not see a new MACTIL classification.
So the classification was a refined classification to the already published data, but then we were able to follow up patients in the Indian cohort, and the visual acuity.
No, I just want to have a visual appeal of a new classification which you made.
Yes, sir.
Can I have a look at it?
We had slightly varying data to the outer retinal hyperreflectivity, which was a grade 4 in our classification actually. And also the vision in our population was slightly better preserved compared to the Western data in the initial stages. So our data actually corroborated more or less to the Western data, but in a more refined way in the Indian population.
Now, my intent of asking you this question was, if I had to just take this into my practice, right? So how do I see a class? With this, it's so hard for me to fathom a classification.
So this is the simplified classification, the table, which shows the 7 grades.
I think these are your results.
Results.
Right? Classification.
Classification is using multimodal imaging, specifically OCT, where we use the permutation and combination of OCT features to see which one of them correlates best to visual acuity decline from good to poor. So the parameters we analyze for, as I said, EZ loss and outer retinal hyperreflectivity, pigmentation, and neovascular, X-rated neovascularization. And since EZ loss has been used as the surrogate marker for assessing the visual acuity decline in MACTIL, we focused on EZ loss, both central and non-central, followed by pigmentation also, because that again contributes to photoreceptor loss and atrophy. So our grading system basically focused on these 4 parameters, and like the vision, we related it to the target visual acuity to compare the grading system.